Welcome back to my channel. Today we are diving into an essential pediatric topic, neonatal jaundice. This is one of the most common conditions seen in newborns, affecting approximately 60% of term babies and up to 80% of preterm babies. So, why do newborns develop jaundice? The key lies in the immature liver and the way bilirubin is processed in their body. Let's take a quick look at bilirubin metabolism before we go to the topic. Bilirubin is a yellow pigment that is produced when RBCs break down. Normally, the liver processes bilirubin, making it water-soluble so it can be excreted through bile and urine. In newborns, due to immature liver enzymes, this process is inefficient, leading to an accumulation of bilirubin in the blood, which causes jaundice. Now, neonatal jaundice can be classified into two main types, physiological jaundice and pathological jaundice. Let's break down each one. Physiological jaundice, this is a normal process in most newborns. It usually appears on day 2 or 3 of life, peaks around day 3 to 4, and then resolves by day 10 and 14 in term infants. Why does this happen? Well, there are three main reasons. Increased bilirubin production due to the short lifespan of fetal red blood cells. Second, decreased bilirubin clearance due to immature liver enzymes. Third, increased enterohepatic circulation, which leads to bilirubin being reabsorbed in the gut. Now we go to pathological jaundice. One, so it's more serious and needs urgent attention. It can be distinguished from physiological jaundice by the following red flags. So, onset within the first 24 hours of life, rapid rise in bilirubin levels, like more than 5 milligram per deciliter per day, higher peak levels, so total bilirubin more than 12 milligram per deciliter in term infants or more than 15 in preterm infants. Jaundice lasting longer than 2 weeks. So these four red flags are uh, for the pathological jaundice. Let's discuss some common causes of pathological jaundice. First, hemolytic causes. This includes conditions where red blood cells break down faster than normal, such as ABO or rhesus incompatibility, G6PD enzyme deficiency, and hereditary spherocytosis. And in non-hemolytic causes, there are infections like sepsis or torch infections, and metabolic or endocrine disorders such as hypothyroidism, which is the most common cause and also important, and breast milk jaundice, which typically appears after the first week of life and can persist for several weeks. Now, thus, we have discussed the classification of neonatal jaundice. Let's explore the two main types of hyperbilirubinemia based on the type of bilirubin accumulating in the blood. We have two, unconjugated hyperbilirubinemia and conjugated hyperbilirubinemia. In unconjugated hyperbilirubinemia, this is by far the most common type seen in newborns. The excess bilirubin in this case is not water soluble, so it can be excreted easily by the baby's body. Some common causes include physiological jaundice, breast milk jaundice, which occurs in healthy breastfed babies, usually after the first week of life and can last several weeks. Hemolysis or hemolysis related causes such as ABO or Rh incompatibility, G6PD enzyme deficiency, and hereditary spherocytosis. And the prematurity, like preterm babies, are at higher risk due to even more immature liver function. So, the major concern with unconjugated hyperbilirubinemia is that if bilirubin levels rise too high, it can cross the blood-brain barrier and causes bilirubin encephalopathy, also known as Kernicterus, which is a dangerous and irreversible condition affecting the brain. So, its complication we'll talk later. Now we go to conjugated hyperbilirubinemia is always pathological and much less common in newborns. In this type, the bilirubin is already water soluble, but there is an issue with excreting it through bile or urine. Some common causes include biliary atresia, a condition where the bile ducts are blocked or not present, neonatal hepatitis, metabolic disorders such as galactosemia or hyperthyroidism. A key point to remember here is that if you see pale or clay colored stools and dark urine in a jaundiced baby, you should suspect conjugated hyperbilirubinemia and investigate for biliary atresia or other serious liver conditions. So, how do we recognize neonatal jaundice and assess its severity? The most obvious sign is the yellow discoloration of the skin and sclera, which progresses in a cephalocaudal manner, that is, from the head to the toes as bilirubin level rise. To assess the severity, we can use Kramer's rule, which correlates the extent of jaundice with approximate bilirubin level. Zone 1, face only when the bilirubin level is 5. Zone 2, face and the chest and bilirubin level is 10. Zone 3, face, chest and abdomen with the bilirubin level 12. Zone 4, arms, legs. So the bilirubin level could be 15 milligram per deciliter in this zone. And the zone 5, entire body and bilirubin level more than 20 milligram per deciliter. However, clinical assessment alone is not enough to determine the exact bilirubin level. We need lab investigations to guide diagnosis and management, especially in cases of severe jaundice. Red flags that may indicate serious underlying pathology include jaundice appearing within the first 24 hours of life, lethargy, poor feeding, or a high-pitched cry, stiffness or arcing of the body like opisthotonus, which may suggest acute bilirubin encephalopathy. So, when we encounter a jaundiced newborn, we need to run some investigations to determine the type and cause of hyperbilirubinemia. Common tests include serum total and direct bilirubin levels to differentiate between unconjugated and conjugated hyperbilirubinemia, blood group and Coombs test to check for ABO or Rh incompatibility, and CBC for anemia or infections. And peripheral blood smear useful in cases of suspected hemolysis like G6PD deficiency, hereditary spherocytosis, and G6PD screening, especially in populations with a high prevalence of G6PD deficiency. That we have covered the types, causes, and investigations of neonatal jaundice. Let's move on to management, which is key to preventing complications like Kernicterus. Management depends on the severity of hyperbilirubinemia, the underlying cause, and whether the baby has risk factors such as prematurity or hemolysis. The three main pillars of treatment are phototherapy, exchange transfusion, and treating the underlying cause. In phototherapy, actually, this is the first line treatment of most cases of neonatal jaundice. It works by converting unconjugated bilirubin into water-soluble isomers that can be excreted in the urine and stool. Key points to remember about phototherapy, like indications, we use a bilirubin nomogram that takes into account the infant's age in hours, bilirubin level, and risk factors to decide when to start phototherapy. It has types: conventional phototherapy that uses blue light, intensive phototherapy delivers higher irradiance and is used in severe cases. It has side effects like dehydration. Babies under phototherapy may lose more fluids, so we need to monitor hydration status. And loose stools is also a side effect. And the other one is Brown's baby syndrome. This can occur in babies with conjugated hyperbilirubinemia. The exchange transfusion in severe cases where phototherapy fails or if bilirubin levels are dangerously high, we may need to perform an exchange transfusion. This involves removing the baby's blood and replacing it with donor blood to rapidly lower bilirubin levels and treat anemia if present. And the indications include total level bilirubin levels approaching critical threshold on the nomogram and signs of acute bilirubin encephalopathy like lethargy, seizures, and opisthonis. The risk of the exchange transfusion are high because it can cause complications like electrolyte imbalances, thrombocytopenia, and infection. The third one is treating the underlying cause. So we can use antibiotics promptly if infection is suspected and sepsis is suspected. ABO or RH incompatibility, we give the IVIG if hemolysis is severe, and the G6PD enzyme deficiency, avoid triggers like fava beans and certain medications. The biliary atresia requires early surgical intervention, typically with the Kasai procedure. If neonatal jaundice is not treated appropriately, it can lead to serious complications, the most feared of which is Kernicterus. Acute bilirubin encephalopathy occurs when bilirubin crosses the blood-brain barrier and deposits in the basal ganglia and brainstem, causing neurotoxicity. Clinical signs, we have early signs like lethargy, poor feeding, hypotonia, and high-pitched cry. Intermediate signs like irritability, hypertonia like stiffness and arcing of the body of like it's called opisthotonus, and advanced signs like seizures, apnea, and coma. And in Kernicterus, it's also known as chronic bilirubin encephalopathy. If bilirubin encephalopathy is not treated, it can cause permanent brain damage, known as kernicterus. This is characterized by movement disorders like choreoathetosis, and this is the involuntary breathing movements, the hearing loss, dental enamel hypoplasia, and cognitive impairment. This is why early diagnosis and treatment of neonatal jaundice are so crucial. Finally, let's talk about preventing neonatal jaundice and ensuring proper follow-up for at-risk babies. Early and frequent breastfeeding helps reduce the risk of physiological jaundice by promoting bowel movements which eliminate bilirubin. Screening before discharge. Check for jaundice in all newborns before they leave the hospital using transcutaneous or serum bilirubin levels. Identify risk factors. Babies with risk factors such as prematurity, G6PD deficiency, or a family history of jaundice may need closer monitoring. The follow-up for babies discharged early before 48 hours. Arrange a follow-up visit within the next 2 days to check for jaundice and ensure they are feeding well. During follow-up visits, assess for any signs of worsening jaundice, dehydration, or poor feeding, and repeat bilirubin levels if needed. Before we wrap up, let's summarize the key points. Neonatal jaundice is common and usually begin, but it can sometimes be a sign of serious underlying pathology. Physiological jaundice appears after the first 24 hours and resolves by 10 to 14 days, while pathological jaundice appears earlier, rises more rapidly, and lasts longer. Unconjugated hyperbilirubinemia is more common, but conjugated hyperbilirubinemia is always pathological and requires urgent evaluation. Management includes phototherapy, exchange transfusion, and treating the underlying cause. The most common complication is Kernicterus, which is preventable with early diagnosis and treatment. Thank you for watching.